This is Barb Anderson, medical technologist at Knoxville Hospital and Clinics. I'll be talking today on antibiotic stewardship and urinary tract infection. To understand antibiotics, let's review a history. Penicillin was discovered by Alexander Fleming in 1928. It was probably the 1940s before it had real worldwide use, especially with World War II happening. Even at that time, they discovered that some strains were starting to produce penicillinase and have a resistant pattern. In 1947, the first penicillin-resistant staph was identified. By 1961, methicillin-resistant staph was first detected in Great Britain. By 1991, 4% of all fatal bloodstream infections in the United Kingdom was caused by MRSA. By 1999, 37% of all of the fatal bloodstream infections were responsible with MRSA. In Iowa, in the United States, from 1997 to 2000, there was one Iowa study that said that approximately 17% of the population had MRSA, even when they had no sign of infections. It was just part of their normal flora. By 2016, those Iowa rates have changed to 30 to 45% of staph cultures are MRSA. But staph is not the only resistant organism. There's a resistant strep. It's called vancomycin-resistant enterococci. There are gram-negatives that live in your intestine and in the environment. They're extended-spectrum beta-lactamase producers. They produce enzymes that destroy antibiotics. There are multi-drug-resistant tuberculosis. There are untreatable sexually transmitted disease that have to have combinations of antibiotics to attempt to treat. There is a drug-resistant Candida auris now, which is a type of yeast infection happening in bloodstream infections that has emerged in 2016. By 2017, there's 154 cases, mostly on the East Coast in New York and New Jersey. They've tracked this from coming from outside the United States. Most people recognize E. coli 0157. That's a type of bacteria that caused an outbreak based on beef products in a restaurant on the West Coast. Klebsiella is one of the gram-negatives that also has developed a resistance pattern to one of our heaviest antibiotics, the carbapenem group. Antibiotics kill our normal flora right along with the pathogens. And when that normal flora is altered, there's a possibility for increasing another organism, Clostridia difficile, to overgrow. That can cause a very bad infection in the intestinal tract. We track these now on a federal website called the National Health Safety Network. The White House decided that if we could get the whole country together, that we might be able to combat this resistant patterns quicker. If we could slow down the emergence of these bacteria and prevent the spread, if we could get all of the different organizations focused on it in surveillance efforts, if we could have new rapid diagnostic tests to help us out, this would work with research and development and get more collaboration between organizations. So fostering antibiotic stewardship is not just only in healthcare settings. They would like to have this happen in inpatient settings, outpatient settings, and long-term care facilities. Some of their goals that they are setting is reducing inappropriate antibiotic use by certain percentages. Outpatient settings, they'd like to reduce it by 50%. They know that we have 154 million prescriptions a year written in doctors' offices and ERs, and they're estimating that a high percentage of these are unnecessary. In the outpatient prescription area, about 44% of those are just for patients with acute upper respiratory conditions. This is one of the areas that they think that they can do some improvement. So by the year 2020 is the goal for doing some elimination of some of these prescriptions. This is a graphic from the CDC that shows some education processes with coordination of the White House Action Plan and the CDC and reducing some of these bacterial treatments. Preventing infection is also one of the greatest ways to slow down resistant infections being created. Immunization is one of the ways that we can stop getting certain kinds of diseases or even flu, and that reduces the number of secondary infections that people get that they use antibiotics for. If we have safe food preparation in the commercial area, in people's homes, that is also going to reduce infections. Hand washing is still the #1 way in the United States to prevent infections. So increased hand washing in healthcare facilities and in the general population will cut back on infections. If we use antibiotics only when they're directed and only when they're necessary, we will slow the spread of resistance. The tracking process is being handled by the CDC, which is a great organization for making sure that we're all using the same strategies to prevent infections. There are many different types of infections and many body sources, and they're doing a great job working with that. So to improve our prescribing and stewardship, we really need to change the way that antibiotics are used. There's a great amount of belief that a large amount of the antibiotic use in humans and animals is unnecessary or inappropriate. Unnecessary meaning we use it for a flu or a virus, or inappropriate may be the wrong antibiotic for the wrong infection or the wrong dose for the wrong number of days. We can also decrease antibiotics used in animal feed. Many turkey and chicken operations use treated feeds, and this develops resistant bacteria also in those animals. So if we can use the right antibiotic and administer them the right way, that falls into a category called antibiotic stewardship. We know that bacteria are going to evolve and change. We can slow that down, but we can't stop it because antibiotic resistance occurs as a natural process. If an antibiotic kills off 95 to 97% of the bad bacteria, then we know that 3 to 5% is going to continue to be present and develop a resistance to that bacteria. And in time, that may overgrow till it becomes part of your normal flora or ready to cause an infection the next time. So if we're able to keep up with a resistant antibiotic and use the appropriate diagnostic tests, we can stay ahead of some of this evolving process. This is really a big change for us. There's a large coordinated effort for all types of hospitals, and even our Medicare and state inspection processes are going to be looking to us to be working on these antibiotic stewardship processes. And so it's a very, very big project. We're going to just start with using some programs. The Antimicrobial Stewardship Program is going to be based on streamlining or de-escalating antibiotic therapy, using education and information to help providers and patients, managing our protocols, looking at our guidelines to help people be more streamlined, doing surveillance monitoring, and doing formulary restriction. That means using the really big guns antibiotics for the really big problems. Our stewardship program here is going to be based on strategic plans that are supported by the Infectious Disease Society, the Society for Healthcare Epidemiology, and the CDC. Our program is going to report to our medical staff multiple times a year so that they can see how our utilization of antimicrobials is working and whether we have some increased cost effectiveness or not. This is a team process. So our antibiotic stewardship team has a physician champion that is able to provide peer-to-peer consultation. Our pharmacist is trained in infectious disease and has access to specialty pharmacy. We have a nurse champion, and I serve as the infection preventionist. The antibiogram is one tool that we use here. This is a process of looking at an organism's susceptibility or resistance panel to the different antibiotics that we test for. Physicians are able to use this. Pharmacy can review this. So physicians can get an idea what antibiotic to use, perhaps before we have the culture results back. These therapies are still not just based on information. We have to look at the patient's history. Where is the body site that they have infection? Do they have drug allergies? What organ is going to be doing the drug excreting? Is it going to be liver? Is it going to be kidney? Have they had to use antibiotics and things before are all considered. The sensitivity test is a part of a normal culturing process. When we collect samples from wounds, urine, blood, or body fluid, then we're going to apply that to an agar plate, incubate it for 24 to 48 hours, and see what type of growth that is on that. Then we are able to take those organisms specifically and identify them. We can add them back onto a culture plate. This is an example in the photo of a disc drop method. Each of these discs are impregnated with a certain amount of antibiotic. There's a zone of inhibition around those that shows where the antibiotic is keeping the bacteria from growing on that agar. This is another 24-hour period on top of the initial incubation, so this is not a fast process. But we are able to determine which antibiotics are best to use for that. There are some new testing processes and equipment using DNA analysis where they're able to take bacteria growing out of broth, like in blood cultures, and do a DNA analysis and give us an idea what they believe that organism to be, so that we don't have to wait 48 to 72 hours to at least get an answer. Here's an example of an antibiogram. This is January 2016 through December of 2016. Across the top are the antibiotics that we have tested for, and down the left-hand side are the organisms that were detected. So the very top line there, we have 71 isolates in that year's period of time that grew out an Enterococcus, which is a type of strep. You can see across this row that there's not a single one of those that is 100% effective against this organism. So the providers are going to look at the ones that have the highest percentages and choose the best one for their patient based on their specific condition to trial. There's two different kinds of Staph aureus that's listed on this list, the ones that are sensitive to methicillin and the ones that are resistant to methicillin. And you can see with the number at 63 in this time frame that about 45% of all these Staph aureus cultures were MRSA in this year period from this county. So there's some variations between those two, different sets of percentages that are all going to be judged in how the physician chooses which antibiotic to use. Strep pneumoniae across the bottom, we can see that one of the lead antibiotics that used to be used for treating pneumonia was penicillin. But in this time frame, the number of isolates that were here, 40% of them were not even sensitive to penicillin. So that has changed over time. One of the most common cultures that we do is urine. And when I was in school, urine was always considered a sterile body source. Well, it's differently looked at now. Urine is not basically sterile in all persons. Excuse me. Bacteria are present in the urine of healthy people who may not have any urinary tract infection at all. And this has really changed how we think about infection. It's most generally assumed that if you have bacteria in your urinary tract, you have an infection. But here's a new term for us, asymptomatic bacteriuria, which is the presence of sufficient bacteria in a sample to give you a positive culture, though the patient has no sign or symptom of urinary tract infection. Here's a chart of how prevalent this is. If we just look at the general population of females, up to 5% of those persons that are totally healthy will give you a positive culture. If they're expecting a child, that rate goes over 9%. If you add some age ranges into it, it's up over 8%. If you add diabetic patients, the results go higher. If you look at elderly men or women, the results are 19 to 16% are going to give you a positive culture. If those persons are living in a long-term care facility, look how dramatically these numbers change. 40% of the men, 50% of the women living in a long-term care facility with absolutely no signs or symptoms of urinary tract infection are going to give you a positive urine culture. If someone has a spinal cord injury, or they may be using devices to drain bladders, if they have hemodialysis, those are all significant differences from a normal person. If they have a catheter in place, short-term, 23%. Look at the last line. Patients with indwelling catheters, long-term, 100% of those persons are going to grow out a positive culture when they have absolutely no symptoms. So we're going to have to evaluate what our symptoms are and make sure we're correlating symptoms with our lab results. Symptoms are usually fever, shaking chills, back pain, side pain. This costovertebral angle tenderness is going to be anywhere from the hip to the middle of the abdomen and down into the pelvis. Blood in the urine. If people do not have catheters or their catheters have been removed, we're going to be able to see if they have some kind of dysuria. Do they have frequency? Do they have urgency? Do they have in urinary incontinence? Any of those things are going to be actual signs that they have a urinary tract infection. But signs and symptoms are not always what they seem. One of these cases in altered mental status does not automatically mean you have a urinary tract infection. Malaise or being lethargic is not a sign of a urinary tract infection. Even persons who have cloudy or foul-smelling urine, that does not necessarily mean that you have a urinary tract infection, because many people have bacteria in their urine systems without having any other symptoms. Altered mental status. Lots of people have distinct symptoms, but these may not always happen in older and seniors. Instead of pain, they may have increased signs of confusion or agitation. They may act withdrawn. In lots of older adults with dementia, we may think these changes are part of their advancing condition. But if an underlying urinary tract infection is unrecognized, it can spread to the bloodstream. It could become life-threatening. But urinary tract infections are not the only cause of altered mental status. So don't stop with the urine analysis only when you're evaluating a patient in that condition. Asymptomatic bacteriuria recurs every 6 to 8 weeks after you've treated them. So if you treat a person with antibiotic therapy, it's going to kill off the bacteria in their urine sample, but in 6 to 8 weeks, that's going to return. And so that pattern of treating and testing and treating and testing when they don't show any other sign of a urinary tract infection, that creates resistant bacteria. So the root of this person's problems may be in assessing whether they have dehydration. Do they have some evaluation of medications that needs to be completed? Do they need to have some other lab tests that assess whether they have cardiac issues, whether they have congestive heart failure? Do they have some other brain or thyroid dysfunction? We've changed the urine reflex rules that we're using in-house. A urine analysis is a dipstick and a microscopic exam. The urine analysis culture, if indicated, means that we're going to do the dipstick, the microscopic exam. We're going to look and see how many white blood cells there are per high power field for us to decide to reflex to a culture. We're using the level of 10 currently. The prior level was 6, so this has been a change in what we usually review. Because it's critical for the healthcare provider to be able to know the patient's history and symptoms and to look at their lab results, we never base their definitions and their diagnosis on just their urine analysis alone. We have to look at the whole picture. Physicians can order a urine culture at any time with any urine sample. You don't have to use the urine culture if indicated criteria. But many institutions across the nation, including the Mercy Health Network and their affiliates, are all modifying the way that they look at urines and the way that they reflex urine cultures. If the sample gives us greater than 10 WBCs, we're going to reflex it to the culture, regardless of whatever the patient's symptoms are. So just make sure that you're aware of that. We've initiated this criteria in July of 2017 with our med staff approval. And it is important to us to have the med staff approval. Medicare requirements are that the med staff sets the criteria for this reflexing. One of the problems with urine collection is getting contaminated samples. Lots of people don't realize that the first 2 to 3 inches of the urethra is colonized with skin flora. So if you have a patient collect a sample in a collection container like a hat, that's going to be a contaminated sample. We use processes called clean catch or washed midstreams. Those basically mean that we're going to have the patient's body clean around the area that they're going to produce the sample, and that we're going to attempt to allow the first part of the sample to be passed and then collect the mid to the latter part of the sample. This can be pretty difficult to do for people who have physical limitations. They may not be able to clean themselves, they may not be able to hold the container in the appropriate place to collect it. So if you have persons who've had multiple contaminated samples trying to do clean catch, then you should consider using a straight catheter collection. Chronic patients that have catheters can become colonized very quickly. So the placement of a new catheter should be kind of coincided at the time that you're needing to collect a sample to see if they're having some problems. Existing catheters become contaminated with a biofilm over time. Multiple kinds of bacteria can live and thrive in this biofilm. And so we can actually get multiple bacterial types coming out of a catheter sample that don't have anything to do with what kind of bacteria that the bladder may be dealing with. It may just be what is in the biofilm that's inside that equipment. So it's a good time to make sure that you've changed the catheters to get new samples. We use a duet catheter system at the hospital that has a special bulb set up that reduces the amount of damage to the inside bladder wall that helps us reduce the number of infections that we have also. So I'm hoping that this information helps you understand our efforts to improve antibiotic use. I thank you for your time and your efforts to help patient care all the way around. If you have any questions, you can call or email me. I have my information here on this last slide. I appreciate your time. Thanks very much.